The new Women's Health Concern fact sheet has been published today on the topic of surgical menopause, and I wanted to highlight some of the very important evidence-based research that's now available to help you understand the consequences of surgical menopause and the management options available on the NHS, because I see so many women in my clinic who sadly have had little to no guidance. So hopefully this video will be able to help you for your next appointment if this has happened to you. Surgical menopause is a removal of both ovaries when you've had a hysterectomy, or that's known as a removal of the womb. So when both of your ovaries and your womb have been taken out for all the right reasons, that leads to surgical menopause. Having this type of surgery allows you to have your quality of life back. So for example, if you've got endometriosis, adenomyosis, fibroids, PCOS, severe ovarian cyst or severe PMDD, having your ovaries out does make sense. And in some cases, it can be life-saving, especially if there's concerns about cancer changes, or if you have a family history or a risk of BRCA1 or BRCA2 gene, which puts you at risk of breast cancer or ovarian cancer. And sometimes we can have to take out the ovaries and the womb, say in emergency situations such as an ovarian torsion or ectopic pregnancies. There are so many reasons why we have to take your ovaries out, and then that can lead to surgical menopause regardless of what age you're at. Now, removal of both of your ovaries leads to menopause, but it's not the same as the natural menopause that you go through. You will go through some very significant differences. Having this type of surgery will lead to a sudden drop in estrogen levels, something known as a crash menopause or a sudden onset of menopausal symptoms, which may be more severe than the natural menopausal symptoms that you might get. If you go into surgical menopause below the age of 45, this is shown to have an increased risk of osteoporosis, cardiovascular disease, stroke, dementia, and your overall mortality. Yep, you could die quicker if you go into surgical menopause before the age of 45, and we are not replacing your hormones. And finally, removal of both of your ovaries results in 50 decrease in your overall testosterone production. And that is vitally important for your sexual function, your bone health, your cognitive function as well. So therefore, we know that women really struggle. So the management section of this paper highlights that if you've gone through surgical menopause, we should be replacing estrogen as soon as possible. We should also be thinking about progesterone if you're having sleep issues. Please look at my video about menopausal sleep issues and how hormone replacement therapy, particularly utrogestan, micronized progesterone, can help with that. And also think about testosterone as well. What this paper also highlights is that for those women who have BRCA1 and BRCA2 gene and have gone through the surgery of having their ovaries removed, actually, for these women, taking HRT after surgery has not been shown to adversely affect the reducing risk of the surgery on later risk of breast cancer diagnosis. So this is really reassuring. So patients who've gone through surgical menopause with a family history of BRCA1 and BRCA2 gene can consider low-dose estrogen as HRT. So to answer the question, how soon should HRT be started? As soon as possible after surgical menopause, to reduce the possibility of sudden onset of severe symptoms. And the same goes for low-dose topical vaginal estrogen and DHEA, as such as Intra-Rosa. Again, it says that as soon as possible that these can be used for women after their surgery to help them with their vulval vaginal symptoms, particularly to prevent genitourinary syndrome of the menopause or vaginal atrophy. And what about testosterone? Sometimes testosterone replacement is offered alongside HRT after surgical menopause because the resulting 50% decrease in testosterone levels. So please do not shy away from asking about testosterone. Speak to your doctor, particularly if you're having low libido and psychological symptoms or relationship issues. Those are sometimes such taboo topics, but please do talk to your doctor about that. As always, I hope that's been helpful. Please do leave any questions down below and I'll answer as many as possible.